Okay, so welcome everybody to Did You Know? So we kind of got those preliminaries out of the way. We're taking attendance, as I said earlier, so we will announce the winners for tonight's prizes. We have a $25 Amazon gift card and $5 Starbucks and a badge holder and lanyard for tonight. So, so Jen's gonna go over our purpose and the introduction of our speaker tonight.
Okay, so the purpose of this Did You Know series, this came about after we had a few kind of errors or missteps happen on the floor that were things that we weren't traditionally seeing in the past. So we had a lot of discussion about why some of these things might be happening. And sort of came to the conclusion that our experience level, as we all know, is a lot less on the floor than it may have been in years past. So people who are having to precept other people may not themselves have some of the knowledge of the things that are traditional 9 North type surgeries or procedures. So we kind of needed to do a little level setting to try and get everybody kind of on the same page, because you can't teach what you don't know. So after discussing that and some different ways we might be able to get that information out there, we decided that maybe just doing a little short informational series with our 2 biggest services, which are Onc-Endo and thoracic. And most of the issues that we have had that have come up have been, with those kind of patients because they're so complicated. So we decided to focus on them and then kind of have a night on quality, because I know every morning y'all stand at the board and you hear Erin talk about our quality numbers and pressure injuries and K cards and all of that. But I don't know that a lot of people have ever really been told why K cards exist, what they're actually doing, like why this data is important. So on that last night, Marche and I are going to kind of go over some of that, present some of our data and some of the wins. We've had some real wins in our quality stuff lately, but all we ever talk about is the need. We forget to tell y'all about the great job you're doing. So we want to kind of present some of those wins. So that's kind of the purpose of this night. Tonight, Bree is going to be presenting, our nurse practitioner from thoracic. I know she's been, as long as I've been here, Bree's been here and has been in that position. So she definitely has tons of experience and knows what she's talking about. She's going to kind of go over the things that they most think that 9 North needs to know about their patients, about the procedures and things like that, to kind of hopefully get us all set at an area where we feel more competent with dealing with those patients. So with no further ado, I'm going to go turn this camera so that y'all can see Bree, and we're going to let her take it away. And then at the end, we will do our drawing for our prizes.
And we also have a question and answer period.
Yes.
After
our
Bree's presentation, so that way everybody will have an opportunity to ask questions if you have them.
Where's
Should
our
I scroll
camera?
that up so they can see my stuff? Or is it-
That's up to you. I can't see our camera.
I just don't want to be too tall.
Admit them. Okay.
I'll tell you,
Can you see Bree right now?
yes.
Okay, I see it now. There we go. However you want. You comfortable there? You're good there. Okay. All right, Bree, take it away.
Hi, most of you know who I am. My name's Bree. I'm one of the nurse practitioners on thoracic. I age myself. I've been working on thoracic surgery for 18 years. So when I feel like, and those of you that have your cameras on, I appreciate it because it's really hard for me to talk to nothing. So see, thank you, Brianna.
Yeah.
Can you see me?
So I, just like Jennifer said, I feel like if you understand some of the reasons why we get really anal retentive about certain things, then that'll help you do it better. If you don't know why something's important, then I can't expect you to then do it properly. So the first thing I want to go over is, I feel like a big kind of learning curve has been the esophagectomy patients and the NG tube. So when you do an esophagectomy, it's a little bit different than the NG tube for any other kind of patient. So this isn't really an NG tube in the sense that you guys think of it. It's more of a monitoring device. So the esophagus is a muscle. It moves, it has peristalsis. When we do an esophagectomy, we can take up to 2/3 of the esophagus out. And then we pulled the stomach up to make a new esophagus. The thing is, the stomach is basically a sac. It doesn't have that muscular movement. It doesn't function the same. So this tube, the reason why it's different is it's not in as far as a normal NG tube. So there's no like checking it for air. You're not going to hear anything in the stomach because that's not where it is. Their stomach is now way up here in their chest. So this thing sits kind of where our anastomosis is, and that's where we hooked everything together. And it's very delicate. It is like sewing together tissue paper. And what we're trying to do is make sure air and all of the natural juices that are on the inside of your body for a reason and gas leave the patient so the patient doesn't retch. People can blow this anastomosis open with forceful coughing. We've had patients even after they've gone home blow it open with a CPAP machine. So it's very delicate, and that's why we're always fiddling with it and messing with it. So that's why absolutely no way, no how will I ever ask you to put meds through this. No way, no how should there be tube feeds through this. And you find an order for that, you need to call one of us and say, what are you doing? So I feel like it goes two ways. I have a bad day too, and I'm tired too, and sometimes I put it in wrong. There are no tube feeds through this tube. There are no meds. The only thing that gets flushed through this is a little bit of water and some air. The other thing that we're kind of finding with it comes out, that's the reason why when it comes out, we're not having you guys put these back in. It's a very delicate procedure to put these back in blindly. And even I have stuck it right through the anastomosis and stuck it right into the chest. I've done it, so we're never gonna ask you to do it. The other thing is this little blue cap, this little cap right here, it will always not be there. What I do want you guys to do is to open a new one and put it back on there. So if you do, I'm gonna pull it off, and if you keep doing it, I'm gonna throw it at you. The reason why is this isn't functioning like a normal NG tube. So I need this to be a pop-off valve for air. So when it's having that little something annoying noise or a little bit of juices coming out, that's good. That's what we want it to do. I get it's messy. So if you want to put like a little towel or a little washcloth, I'm all about protecting your bed. I was a bedside nurse too. I'm all about that. But what you can't do is put tape around it or ACE wrap or so tight that this thing can no longer have, it has to be able to have air through it because it's not functioning as an NG tube, it's functioning as a pop-off valve. Does that make sense to people?
Yes.
Okay. Is there anything about NG tubes that you don't understand or want me to answer? And also know that like we're around all the time. So if there's ever a question or concern, just find one of us. And then the next thing I feel like is the big thing on our services, I call it the International Box of Mystery, AKA the Pleurovac. So I decided to bring one in the package so I could set one up for anyone that isn't familiar with that. And then kind of explain that why all the way you set this thing up is important. So why it's so important, all these things I talked to you about the Pleurovac is because you're our eyes and ears. And I've had a patient go from the OR to the PACU to 9 North. And it wasn't until the patient got to 9 North that someone realized there was no water in this Pleurovac. When there's no water in this Pleurovac, you can actually create tension physiology for someone. I've had 2 patients actually go back to the operating room because there was no water in the Pleurovac. So we rely on you as much as you rely on us. So when these things come out, and then there is a thing of water, and it goes, can everyone see that? Right here, that's where this goes. And it goes up to this line, and if there isn't enough water up to that line, it needs more water in it. Because that is what's controlling the one-way valve of this Pleurovac. Without enough water in there, there's no more one-way valve and this thing becomes two-way. If that makes sense. And the other, yeah, you can just put saline in there. Use like some sort of funnel. I wish it came with a funnel, but it doesn't. The other main thing that I want to make sure everyone understands is because there's this water, once you have the suction tubing on to the wall, it does not matter how high that suction is. The suction is controlled by this dial. So you'll see us kind of playing with it up and down. So it doesn't matter, like when we're getting called about suction or you're asking us about suction, it's all based on the box, not on the wall. And then the only two settings you're gonna have is suction, which is when it's hooked up to suction. And you always have to make sure that the suction's actually on the wall. Because once the suction's on, there's a little orange little stopper and it'll pop off. And if it's not on suction, then that is in. And the only things we're gonna ever really have you do is hook this up to suction or hook it up to water seal. There's not much more other than changing this quarterback out that I'm gonna really ask you guys to do. And then the other thing I kind of wanted to talk about was when we have chest tube dressings and we remove the chest tube. So what I do not want, I'm a tape minimalist, and there's a reason for that, is chest tube should have like, around it should have like one piece of gauze and then like another piece of gauze over it and just enough tape to keep that tube secure. I get that sometimes they're messy and they ooze and they drain, but if you put 17 ABD pads on it with 17 pieces of tape, that leakage still happens. And what's under it looks like diaper rash. No one wants diaper rash on their side. It's not cute. And then you're basically that using it often is a little bit high maintenance, but what's also high maintenance is when your patient has breakout or you're doing skincare. So it may be a little bit more time consuming to change the dressing frequently. And I'm also like, we're on your team. If I come in there and I notice that it needs to be changed, I'll change it too. Like we're in this together. But what I don't want is to see 17 ABD pads on it and 17 pieces of tape, because then I have to take all that off and give the patient like a wax that they didn't sign up for. The other thing I want to make that I feel like there's some confusion about is when we take the chest tubes out and we put a dressing on. Yes, that is we use the silk tape, and I get that some patients are allergic, but we try to minimally, what we need is there to be an occlusive dressing, because for at least the first 24 to 48 hours, that can almost be a two-way connection. And people, as you know, I call it farting or burping through the skin. So that air needs ways to get in and out. I think there's confusion over changing the dressing, and I just kind of want to clarify it. It's for the first 48 hours, there needs to be an occlusive dressing on that. That does not mean that if it's completely saturated, that you can't change it. You can change it, because we all want, like, again, our skin to be nice, but what it needs to be is, again, another occlusive dressing. It can't have like one side kind of flapping open, because depending on how many cheeseburgers someone has on their side, like my skin and fat was probably collapsed all over my chest tube site, and it wouldn't be a problem. But some of these people who have had cancer that are very skinny and don't have enough body mass, they're stuck in air. And you can actually give people pneumothorax from it and drop their lung. So I think there's some confusion over whether or not that you guys can change it. Is if it's saturated and gross, change it. I mean, if you call me to the bedside, I'm going to change it, but it just still needs to be an occlusive dressing. So I don't want anyone to feel like they can't change a dressing. Is there any, I think like that's kind of the big things from our service, unless you guys, I mean, I kind of need to know what you guys are more confused about. And again, as you learn, if you ever like think a chest tube has an air leak and want a little education on what's an air leak and what's not, I'm happy to do that at the bedside, as well as we all are. Or if there's something you just don't understand about the surgeries, we do so many different kinds of things. There's wedges, there's lobes, there's sleeves, there's pneumonectomies. That's a lot. So is there anything that someone on this Zoom feels like they want to ask? And if you don't want to ask here in this format, you can ask Marche or Jennifer privately, or you can just come up to me or one of my coworkers and ask. I'm never going to shame somebody for like asking a question. I always say that there are no stupid questions. There's stupid people who don't ask. So I would rather you ask me the same thing 5 times until you get it than you just assume, because that's how you hurt people. And I know from experience, that's how you can hurt people. I was a nurse once too, I get it.
I have a question.
Sure, Gail.
Thank you. The chest tubes. Moving around tends to be like really painful for the patient. The tube moving, is it okay to put a piece of tape like 2 inches below to keep it from shifting?
Absolutely, absolutely. But what, again, another pet peeve of mine is, everyone knows where the 5-in-1 and the tube meet. You know what I'm
Yeah.
talking about?
Yes.
Not wrap 17 inches of tape around it.
Well, no, I'm just saying across it, just to
And
keep
this
it.
hasn't been really a problem on this floor, but I get consults from other teams because under all that tape, the tubing is apart. And that's why I don't like them taped that way. It's under it, it pulls apart and then basically
Right.
this done.
Right.
I've gotten consults from trauma where after I take all that tape off, it's disconnected.
Yeah,
So it's one of those, I just kind of want you guys to know that the things we harp on for a reason. Because they're important.
yeah. Mhm. Thank you.
What to do?
And okay, they're asking me, what happens if your chest tube becomes disconnected, what to do? One, first is to stick it back together. Now that most of the nights have night shift, go ahead and call them and let them know that happened. As long as the patient's okay, 9 times out of 10, this is fine. But we need to get an x-ray because if someone had an air leak, they may have a space or a pneumo. But the most important thing is to first put that thing back together and then call me or whoever. Or if the tube comes completely out and you find the whole thing on the floor, which I get happens because people like to do this. You put a dressing on it, that's occlusive, that's for, all of it covered, and then you call us. Please put the dressing on and then call me. Or Brianna, or Dratzi, or whoever. And 9 times out of 10, we will come to the bedside. Anything else?
No.
We've got a couple of night shifters on and, so is there anything in specific, because I know the nurse practitioners are typically in-house during the daytime, but at night. Oh, yeah, that's right. And one at night, how, does anybody have any feedback about how that's going? Anything that they would specifically need from thoracics in terms of having a person here at night now?
I like it.
Engineers for these new chips.
I love it.
You tell me if they're getting sassy.
Somebody said they love it.
Now,
Yeah, that
Bree,
was me.
no, they won't get sassy with me.
Know what I'm saying.
Does anybody have any other questions? We've got Bree here to answer anything that you may, we really wanted this to be informative, and so we don't want to assume that everybody knows or that everything is clear. If you have questions, feel free to ask.
No one should ever, I don't consider clamping a chest tube something that I'm gonna ever have you do. And if anyone from our service ever asks you to, please let me know. And it's not that I don't trust you guys to do it, but it is something that's advanced. I feel like if you're gonna do something like that, you need to be prepared to be able to deal with the aftermath. And we do clamping of chest tubes in very specific situations. And also, I know that there's a lot of chest tubes on other services, and if you ever have questions about those, I mean, I know that those aren't mine, but if you have like a pigtail from another patient, you're just unsure about something and don't want to call the team, and maybe I'm a little bit more accessible, or I'm a little bit less intimidating, even though I've been told I'm intimidating.
I have a question. When we have to change out the Plurivac, what's the process that you have a patient going through to actually change it?
So changing out a Plurivac. I think all of you guys probably know this, but when I've gone to other floors, they seem to want to make it really complicated. You don't need to like clamp the tube and undo stuff. This thing comes apart like right here. So you just set up your other Plurivac right next to it. You go. That way you're doing it so fast, you don't even really need to clamp it because you're doing it so fast. But I've gone to other floors where they're doing all sorts of shenanigans with cutting and taking it apart. And the whole goal is that this thing, if you ever seen one of these put in, is put under sterile. It's sterile. Until we intervene with it, it's sterile. And so we try to keep it that way as long as possible. So this part, of course, is not sterile, but this whole part up here, we're trying to keep as sterile as possible. So I don't want you guys taking it apart.
Easy peasy.
Easy peasy.
But I mean, you'd be surprised how many people make this stuff harder than it needs to be. At least you guys don't have
Bree,
lung transplants anymore, because they have 6 of these.
this is Wendy. I have a question from a care partner standpoint. I guess I could probably have asked one of the nurses, but since we're doing this, what exactly is the point behind a patient having a chest tube?
So step 2, when we do for our thoracic patients, is all of the procedures we do, we enter the pleural space. So this tube is not in the lung, where a lot of people think, oh, I got a tube in my lung. No, it's not. I like to describe it as if your chest wall was a jelly jar turned upside down, and the lung is a balloon inside of that jelly jar. This tube is in between the two. It's a straw in between. So when we cut on lung tissue, I wish it healed up like a zipper, but it doesn't. It heals more like paper mache back in 5th grade, if anyone can remember doing that. And we have to wait for all those cracks and nicks and stuff to heal. Everyone does that at a different pace. And there's a difference between operating on a 25-year-old that's never smoked a cigarette in their life versus a 75-year-old that smoked till the day they came in here. As it's leaking air, this tube is keeping that lung expanded. Without this, that air that's leaking out has nowhere to go, and it will cause a tension in the thorax. And then there's also a lot of the surgeries we do, it's just to drain fluid and air from the surgery.
Okay, and I have one other question. A lot of times patients will ask me, what are they looking for in the chest tube? How will I know, or what will they look for in order to know that it's time to take it out? I have no clue what y'all are looking for.
So first of all, I'm looking at the character of the drainage. The drainage should always be thin, but it can be various shades of color. So as long as straight blood, is straight blood. It's thick. We all know what that looks like. But the way to describe, and this is also for you, I think for nurses, is people will freak out and think like, oh my God, there's so much blood in here. And you have to kind of describe it as when you put a drop of food coloring in a glass of water, how red it turns with just one drop. Or if you're like coloring frostings, and it's not that this is blood, it's just maybe there's one drop of blood in it. And pleural fluid, normal pleural fluid is a pinkish, reddish, yellow color. So I say it can go anywhere from Merlot to sweet tea. It can be any of those colors. I love to use examples that people can relate to everyday things, because it kind of puts it in a little bit more of a level where they can wrap their head around it. So first of all, I want to make sure that it's thin and that it's not blood. Because again, like if you see creamy white drainage, that means that there's something else. That's either pus or chyle.
Okay.
The amount of drainage, we would like to see less than 300 in a 24-hour period to take a tube out. But if anyone gets a lobe or like anything other than, so a wedge resection is anything that's not anatomic. That wedge can be the size of a dime, or it can be the size of my fist or a softball. But if it's not anatomic, if it's not a lobe or a segment, it's considered a wedge resection. But if you have a lobectomy or a segmentectomy or anything like that, that tube isn't coming out for probably almost 48 hours. It's just going to stay in from the purpose of we want that patient getting up and moving around. We want gravity to take its place, make sure they get up and moving and get all that fluid out. Once you take these out, the only option to put one back in is at the bedside, which is no bueno like that. So those are and then we're looking when we have one rooms, you'll see that we're obsessed with having people cough and looking at this little chamber on whether or not they have an air leak. So we're waiting for the fluid to kind of cease off and for there to be no air leak. So if we put a tube in any single person in this Zoom call, it would drain almost half a liter. That's just what's in your body at all times, and your body reabsorbs it. So that's why once it's draining about less than 300, we feel safe to take it out because your body will reabsorb that fluid.
Okay, all right, that makes sense. Thank you.
No problem. daily chest x-rays. So daily chest x-rays are just to make sure that tube hasn't moved, to make sure they don't have any new space. A lot of times we're monitoring a space. We're looking at more than just like the chest tube. Our patients have had thoracic surgery. So we're more looking at it from like an all around like pulmonary standpoint, not necessarily chest tube specific, but whether or not that patient needs to get up and move around, if they need mucolytics, if they need that LASIK. So it's more than just the chest tube a lot of times, but while they have a chest tube, patients will get a chest x-ray every day. And then if we do anything significant to the chest tube, just because I'm not Superman and I can't see inside, we usually do a chest x-ray at some point. About once a year, our surgeons decide they're going to be chest x-ray minimalists. And we're only going to do things based on clinical change. And the first weekend that comes, the surgeon who's on like blows that out of the water because they're uncomfortable. So I'd like to say we're going to be chest tube minimalists, chest x-ray minimalists, but never have. I've been here for 18 years and it hasn't happened.
Talk about deep breathing and coughing with the chest tube.
It's so important, but it's gonna hurt. So all your patients will say, I can't. And I'm gonna quote Dr. Nesbitt that says, you can, it's just gonna hurt. You can. It's just, giving a pillow and bracing it. And that's why we rely on you guys. If you guys feel like your patient can't cough and breathe and because of pain, let us know because we'll add stuff for it. I am happy to give people as much pain medicine that they need to do what they want me to do what I need them to do. That doesn't mean I'm always going to shoot them up with Dilaudid, but I have lots of things we use based on the kind of pain. So if they can't get up and move and deep breathe and cough, you need to let us know.
Thank you.
Yes, that's where you read my mind.
Please have my AFib. My patients never go in AFib.
Yes, because that's one of our most common complications.
Okay. So 30% of all patients who have any kind of chest surgery go into atrial fibrillation. The important part is whether or not they're symptomatic. So what I think is important is you as a provider and like me as a provider is not freaking out, because then it just makes everyone else in the room freak out. It is usually temporary. It is related to the surgery. It doesn't mean that there's anything necessarily wrong with their heart. It just means that like the heart's right here and the lungs are right here. And we went in there. I always say God created the ribs and the sternum because he didn't want us to go in there. And then we went in there. So it's usually temporary around it's from the surgery. We primarily treat it with beta blockers and you'll see us do amiodarone. If it's past that point or if a patient already has a history of AFib, you're probably going to see us get cardiology involved, because if a patient already has a history of AFib, the likelihood that they go into AFib is probably about 50%. So when you guys start talking to us about PVCs and stuff, and then you'll see us like add low pressure, or if you see someone's heart rate's kind of like creeping up, I call it fending off the AFib fairy, but basically we will beta block anyone that has room. But the important thing about when patients go into AFib is whether or not they're symptomatic. That's the most important thing. I mean, we can treat the monitor, but the most important thing is like, do they feel okay? And treating them. That, everyone kind of runs in the room and freaks out, and it just makes it worse. But I think once you have a couple of patients, trust me, the first time I had a patient go into AFib, I freaked out too. But the more it happens to you a couple of times, and then it's not going to be anything. It's just going to be what happens. If you work on night nurse long enough, you're going to have one of my patients. And it happens at night, all you night nurses. So we like to keep Marche asked why we keep our patients dry. So thoracic surgery patients are a little bit different than your general surgery patient, whereas there's what the body needs in fluid and what their lungs can handle. And it's basically this very delicate balance. So when we give fluid, you'll see I give fluid to people all the time. But on lung patients, what kind of fluid they can handle is different than what like a general surgery patient can handle, because their lungs are already sick. Like, we're not resecting lung cancer on people because they live the like healthiest lifestyle. I mean, there is that rare like person that never smoked a day in their life and all that, but most of these people, their lungs are already sick, and then we just made them sicker by operating on them. So it's a very delicate balance, and a lot of times when patients So we purposely drive people out in the operating room, and we will give Lasix till people creatinine lump. But a lot of times we kind of have to play with it. You'll see us give Lasix and then give fluid in the same day, and versus when like a general surgery patient will get 500 or a liter, where we're like, give 250 and then give 250 more. It's more I'm trying to figure out if what I'm treating. Like if I give 250 of saline and I get a little bit of a response, I know what I'm treating. If I give 250 of saline and it does nothing for the other symptoms, I know that I need to look at a different cause for whatever is happening. But they're not hypotensive because they're dry. They're hypotensive maybe because they're in pain, or they're getting septic, or they smoked and lied about it. Because you'll all have that patient. There's a kind of a way, the patients who smoked up to the day they had surgery, and there's a difference between the ones that have and the ones that don't. We usually try to have 2 weeks without smoking, but of course people get through the cracks. And you'll see that we're like, we give the breathing treatment, we add the oxygen, you'll see us get Lasix. People either kind of do this and level off, or they don't.
Mhm.
And that's when we're pretty fast at getting someone into the ICU in that situation, because it's gonna keep on going. And that's why we kind of want to know once that's happening, like, you may not want to bother us, but like the difference between a patient being on 1 liter and 2 is important to me. I may not call you back, I may not do anything, but I'm noting it.
All right.
Talk to us about lung volume reduction patients, and like they tend to be so anxious, and we tend to have a lot of needs with them and managing them. So talk to us about them.
So the reason why lung volume reduction patients are so delicate, I would call them delicate little flowers, is there is a very slim window to get a lung volume reduction surgery. It is a patient that is not sick enough to get a lung transplant, but is too sick to get any kind of other surgery. So they fall into this very slim category. A lot of them will slip out of that category really fast. So their lungs are so sick that the only thing we can do is that surgery. And basically all you're doing is taking the very top, which is what for Bleb disease or emphysema, what I call that is if the lungs are like throw pillows, no, the lungs are like the big pillows on your bed. And then Blebs are all the stuffed animals and extra pillows we put on top. When we were like 16, it's all the Care Bears. So we're basically just giving those lungs a haircut, and they're gonna leak air like no one's business. And their lungs are paper thin and they have no reserve. Like a lot of times these patients can't even walk to their mailbox. And it's one of those things where you're not gonna see. The reason why this is kind of hard for you guys is you guys don't see these patients get better. A lot of times they leave with chest tubes in place and on more oxygen than when they came in. But when they come in like 3 weeks or 4 weeks later, or even 3 months later, we have these patients who are running 5Ks, are able to not be on their oxygen anymore. So it's like the acne mimics patient retin-A, where it gets worse before it gets better. But like you're basically operating and you're taking really sick lungs and then operating on them. And so their inside is basically an inflammatory mess.
So you're reducing the lungs so they have less space to feel.
You're
as
cutting
they-
the most diseased part off, but the rest of the lungs, I know you're recording this, but it's still shit. The rest of the lungs are still shit. It's not like we didn't fix anything. We just took the sickest parts off. That whole part up there is angry and leaking air. And these people are so used to like not being able to breathe that when you add pain and chest tubes and all this stuff, it just creates anxiety. And how I treat anxiety is the anxiety we have, just like with sub-Q air, the anxiety is not from their airways contracting or their lungs falling, but that doesn't make it any less real. That's how people can hyperventilate from a panic attack. It's because it's a cycle. Is they get short of breath and they get anxious, which then makes them more short of breath, which makes them anxious. And it's just this cycle that they cannot stop once it starts. And that does not, it's not from a physical cause, but that doesn't make it any less real to that patient in that moment.
Epidurals in the thoracic patient.
What about epidurals? What's the confusion about epidurals?
Well,
You should have a
the
pain team in here.
Usually in the toilet, like what, how do y'all, well,
You
y'all.
put epidurals in the toilet?
No, like their blood
Their blood
pressure.
pressure.
Oh.
yeah.
So the pain team will tell you that epidurals don't make your blood pressure low. I don't agree with that. If not, why do they walk around with sticks? So that's where you'll see us kind of play with volume is, and it's probably a lot of times the hypotension is not specifically epidural related. There is a lot of times it's not, and there's a lot of times it is. A lot of times it's multifactorial. It's that we put a bunch of pain medicine in them, and then we slapped them with an epidural, and then we dried them out, and then we put them in an environment that they don't have, or we added medications, like we beta blocked them too early. So it's usually more than one thing that makes them hypotensive. But that's why you see us give baby fluid for it. It's because and then, you know, sometimes we have to have the epidural taken out. It's kind of a battle that we're always, I don't think there's any way to not, it's just gonna be a battle that we all battle together with our patients.
Question. People who need volume lung reduction, right?
Mhm.
Is the majority of them is due to smoking?
Yes, ma'am.
Okay, that's what I thought, because I usually explain to those patients, if you take a brand new balloon and blow it up and let it out, it comes right back down to where it needs to be. After the 5th or 6th time, it's a floppy little thing.
Exactly.
And I said, and that's what your lungs do. They get thinner and thinner, and then they're harder and harder to repair. You can't let the CO2 back out.
Most
Like-
people who get lung volume reduction, were trying to get a transplant and weren't sick enough.
You're right. Okay, that's what I thought. All right.
Just call
Thank
Dr. Rick Hilton on my iPhone. Be glad, guys, because we're pumping these transplants out like candy
Mm-hmm.
everywhere. Yeah, we've done 3 people who have had lung disease from COVID. We can't transplant from COVID.
Right.
Okay.
But that's what you're also gonna see a lot of, your probably guys are gonna see a lot more, as you can see, we're getting a lot more deportications, we're getting a lot more pneumothoraxes, and a lot of this is COVID related. We're also finding that these patients are, the paralyzed diaphragms. I feel like we've been doing a lot more of those, a lot. Dr. Nesbitt feels like
Yeah.
it might be COVID related. We're actually doing a study to kind of see if that's related to people having COVID.
Oh, I know what, younger age projected, like what kind of things do they present with? 'Cause, I mean, we get like early 40s. late 30s.
Usually the question was how most esophageal cancer, especially in younger people, is diagnosed in 2 ways. It's usually a progressive swallowing difficulty over like weeks.
Like
They just, yeah. Or it's they were getting a chest X-ray for something else. So 90% of lung cancer is actually diagnosed through getting a chest X-ray for something else. Like my shoulder hurt, or I'm sneezing, or I'm coughing. And they do a chest X-ray and we're like, hey, what's this?
Mhm.
Well. Anybody else have anything they want to ask, or, I mean, take advantage of the opportunity?
We were scheduled to finish at 8:30 and it's 7:59, and we certainly don't want to, hold you to 8:30 just because we had that on the agenda. But if there's questions that you have, we'd love to answer them.
I want to know if Bree is in our car.
Do what? Oh,
I want to know if Bree is in her car.
I think she is.
Yes. And Jayla was eating dinner and it looked good. All right. All right.
But also just know, like, the nurses who have been here for a long time know that we're approachable. No one's gonna yell at you or gripe at you. And I know that the last nurse resident education I missed, and I apologize, so that's why I was making sure I got this in, that we don't expect you guys just to know this stuff like that. That's why we're here. And so if you have questions, I mean, I feel, and this is no joke, I feel like 9 North, other than the ICU, is the hardest part. But you're gonna, whenever you move to different pastures, you can work anywhere after you work on 9 North.
But we don't want you to move to different
I don't
pastures.
want you to go anywhere.
Stay in this
Stay in the
pasture.
Stay.
All right. Okay.
I mean, I'm the poster child. We're not going anywhere.
Evidently.
Evidently.
Yeah. I said I'd be at Vanderbilt for 5 years.
All right, well, you want to turn that camera back on this way?
Yeah, let's get it off me.
Bree is done. Thank you, Bree. We appreciate you giving us your time. Real
Good job, Bree.
Yes,
Thank you,
yes, Thank you, thank you. All right, real quick, I just want to run over the names that I have. If you don't hear your name, tell me because I missed you. Some people kind of lost signal and came in and out, came in late, things like that. So I want to make sure I got everybody. I've got Savannah, Gail, Brittany, Cindy, Erica, Christina, Angela, Desi, Blanca, Jayla, Kayla, Caroline, Destiny, Wendy, Alma, Ashley, Bree, Judith, and Anna. Did I miss anybody? Other than the people who were not 9 North or Dana, who's part of management. Okay, awesome. So we're gonna do our drawing real quick. No, I'm gonna let you draw, don't leave. We have our 3 drawings. I have all those names on the slips in my
I
hand.
have a feeling Brianna wants to go in.
This
So
one is for what?
this one first we'll do the $5. Well, I dropped somebody, so we will make sure we're fair. First is for the $5 Starbucks gift card.
Oh my goodness.
Is it like not?
I got it. I think I should win.
Sorry about that. Yeah, all right. So.
Savannah.
All right, yay! I'm gonna put that with that, so I don't lose it. Yes. Then for the Vanderbilt badge holder and lanyard.
Jayla.
Yay, Jayla!
I have another one.
Alright. Oh, okay, good.
And then this
She
is
drew 2 at 1. Yeah, this is the Amazon $25 gift card.
Destiny.
Yay!
Hey, Brittany.
So we will have prizes every night and they're of similar value every night. So, you know, nobody's gonna get shafted, but thank you all for coming. We really appreciate those of you who were able to come live. So you obviously, we have you checked off as already having attended, and we will get this out and recording for other people. Tomorrow night will be on Kendo.
That was cool.
Yeah, so they've got some things to tell us that hopefully you all, you know, and come with your questions, think about it between now and tomorrow night if you have questions about Endo patients, so that we can, you know, get as much information as possible so we can take the best care of our patients possible. You know, we're all in this for the same reason, because we care about the patients and what happens to them. And being the best educated is the best way to be the best nurse. So we appreciate you all. Thank you so much. You all are amazing. We love you and have a good night.
We're gonna send out a survey because we want to know if this was helpful and how we can make it better. And make this kind of like a routine thing and maybe even go through some other services as we go along. But thanks so much.
Thank you. Bye.
Yay.
Bye.